important. So one is flabby tissue. So when we talk about the flabby tissue, it is the formation of excessive movable, mobile or hyper redundant tissue. Remember rightly one thing, that flabby tissue is poor in support. Write down in bold letters, it has come so many times, that flabby tissue is poor in support. It forms when the bone beneath it is resorbed. Then only the tissue will be collected at one place, and it will become redundant, it will become excessively mobile, right? Then there is a term known as epulis fissuratum. Epulis fissuratum is the overgrowth of the intraoral tissues, resulting intraoral soft tissues resulting from chronic irritation. For example, if you have any border of irritating border, denture border, and it will irritate the border and there will be chronic irritation. Okay, then residual resorption we have already discussed in our classes, in DAMS classes, that it is basically what it is: diminishing quantity and quality of the residual ridge once the teeth are removed. So when we are talking about the I'll come on to the main topic. So we have sequelae of varying dentures. We have direct sequelae and then we have indirect sequelae. So when we talk about the direct sequelae or the post insertion problems, we have flabby ridge, we have denture irritational hyperplasia, then we may have traumatic ulcers if still the patient have chronic irritation. If there is so much of trauma again and again, and then it may also turn into oral cancer. Then it is patient might be suffering from burning mouth syndrome. Then denture stomatitis. The first sequelae that we will be discussing is denture stomatitis. Okay, short-term denture effect: patient might have pain, he might have loose dentures, he might be suffering from speech difficulties. Remember that patient require at least 2 to 4 weeks of speech adaptability once you give a denture. Then there might be gagging because the palate and everything is covered, so patient might be having he might not perceive the taste as well as cold and the hot foodstuffs. So direct sequelae, the first sequelae that is important, and it has been asked so many times, is your denture stomatitis. So when we talk about the denture stomatitis, denture stomatitis is so it is basically what? It's a chronic inflammatory condition that affects the denture bearing mucosa. It has various names. Like your denture induced stomatitis, your denture sore mouth, denture induced stomatitis. So it is basically what? It's a chronic denture sore mouth, SCAC, chronic atrophic candidiasis. Then inflammatory papillary hyperplasia. Remember, is that the inflammatory papillary hyperplasia is the type 3 where the papillae are being formed. I will tell you the classification that was given by Newton. Okay, so if we talk about the Newton's classification of denture stomatitis, so we have 3 types of Newton classified denture stomatitis into 3 types. One was type 1. I'll show you the pic. I am talking about denture stomatitis, denture sequelae, those who have joined recently. So type 1 is localized simple. If you see the slide, if you see localized simple hyperemic palate, बहुत कम होगा, localized रहेगा, localized simple inflammation or pinpoint hyperemia. You can see various pinpoint hyperemia you can see on the palate. Type 2, if you can see, this is type 2, and in type 3 you can see the papillae, inflammatory papillae you can see. because of chronic irritation. So if we talk about type 1, I have told it is a localized simple inflammation or pinpoint hyperemia. Type 2, it is erythematous or generalized simple, that is basically seen as diffused erythema of the palate. It occurs in the center of the palate. Okay, यहाँ पे pinpoint hyperemic spots होते हैं and it is more of localized thing, right? But here if you see, it is diffuse, center of the palate is involved. In type 3, you can see it is granular type, inflammatory papillary type, that is commonly involving the central hard palate and the alveolar ridges. And mind you, type 3 requires blunt dissection or cryosurgery. It requires blunt dissection or surgery. ठीक है. Etiology देखो, if some this has been asked so many times that what is the main reason of your there are various reasons, but yes, the only microorganism that has been isolated from the smears of denture stomatitis is your Candida albicans. Write down Candida albicans is the main microorganism associated with your denture stomatitis. There may be other factors, but yes, main reason or the main microorganism is Candida albicans, right? You can see, even if the patient doesn't keep the denture, the hygiene, denture hygiene in a you can see it's in a very poor condition. This may also be the reason. Okay, even if you don't treat it, you can see there will be angular cheilitis or glossitis may be associated with it. Okay, now what are the predisposing factors? Patient will give a very unique history that he does not or she does not remove the dentures. He or she is wearing the dentures day and night. Normally we should avoid dentures at night because your mouth needs rest, right? So if the patient says because of chronic, because it is basically what? It is tissue abuse. So if the patient is wearing the dentures day and night, there will be bacterial infection, trauma. There might be reduced salivary flow associated with it, high carbohydrate intake, poor oral hygiene. Okay, there might be patient might be on immunocompromised. He might be very old. There might be immunosuppressive drugs. Patient might be diabetic, xerostomy, and there might be some nutritional or vitamin deficiencies. These are basically the predisposing factors. Okay, so denture stomatitis, these may be, the patient might be one of these, might not be. So you have to see that. Okay, what are the clinical factors? Mind you, it is normally asymptomatic. Patient will not have any problems. He will just, it will be a recall visit, and when you remove the dentures, patient is perfectly fine. So there are no symptoms, but there are signs that you will have to look. You will see the palate, remove the maxillary denture. Remember this thing that you normally won't see denture stomatitis with respect to the mandibular arch. The maxillary arch is having a predilection or more preponderance for maxilla. Patient in severe cases, patient might have some burning or itchy sensation, but normally it is asymptomatic. Okay, how to diagnose it? Definitely, if we have to isolate an organism, so what we can do is we can take direct smear. We can see it in the microscope, and if you see various mycelia or pseudohyphae in the direct smear, and if you see various colonies, So if you normally find more than 50 colonies, more than a presence of hyphae, pseudo hyphae, and more than 50 colonies, you be rest assured that Candida albicans is involved. Okay, Seema, I'll have a look at it. Don't worry. Okay. What we can do is, Seema, what we can do is we can take it the Seema is asking a question that what cusp to reduce when. What I can do is I can take a separate topic in my next class, maybe tomorrow, day after, whenever, most probably tomorrow 9 p.m. we'll be having a class tomorrow. Okay, so I'll explain there. Okay, so how to manage it? How to manage it? Beta, if you have to manage it, denture stomatitis, first ask the patient to remove the dentures. Don't wear it. Keep the denture hygiene well. If there is any specific region, kindly treat it. There should not be any traumatic area. Okay. Then you can give tissue conditioners. If the patient says that he or she will not remove the dentures, ideally you should remove the dentures. Patient should not wear it. But if the patient is not agreeing for the same, you can use tissue conditioners. No soft liners, mind you. Tissue conditioner, they are more softer, but they have to be changed after 7 days. Remember, because they become hard, they may cause mite damage, more damage after 7 to 10 days. Remember this. Okay, if fungal infection is there, then nystatin, antifungal therapy, miconazole, other deficiencies you can use. Okay, there's no problem. You can keep the denture in chlorhexidine. You can, even the patient can use local lozenges, antifungal, like nystatin, miconazole lozenges. Okay, patient can keep the dentures in 2% chlorhexidine solution. Okay, and if, as I told you, in type 3, we can go for blunt dissection, electrosurgery or cryosurgery. Got it, Seema and others? I can see there are 7 people. क्लियर है? सो नॉर्मली क्वेश्चन आता है कि एक तो माइक्रो ऑर्गेनिज्म कौन सा है, दूसरा आता है कि पेशेंट की हिस्ट्री क्या है. ये ऐसे लंबे लंबे क्वेश्चन आ सकते हैं. ठीक है. प्रिवेंशन में सारी ये जो चीज़ें हैं, जैसे मैंने बताया कि रात को मत पहनो डेंचर्स, पेशेंट शुड नॉट वेयर इट, मेंटेन ओरल हाइजीन एंड डेंचर हाइजीन. ओके, you have to clean the dentures with a cleansing agent like sodium perborate. ठीक, and patient can go ahead with the massage of the soft tissues too. Okay, then we will talk about is the flabby tissues. Okay, flabby tissue, as I told you, इसमें question आते हैं. You can see in the picture that this area, mind you, there is a very important question, that anterior maxilla, write down, anterior maxilla is the most common site of flabby tissue. Write down. ठीक, it is mobile, extremely resilient, like this. You can just आप उसे ऐसे ऐसे हिला सकते हो रिज को, तो उसको हाइपर मोबाइल रिज भी बोलते हैं, रिडंडेंट टिश्यू भी बोलते हैं, फ्लैबी टिश्यू भी बोलते हैं. एंड एज आई टोल्ड यू, दे प्रोवाइड द पूरेस्ट सपोर्ट फॉर द डेंचर. एक चीज़ बेटा हमेशा आती है आपके, इट इज़ गिवन दैट वेन एवर यू आर मेकिंग द इम्प्रेशन ऑफ द फ्लैबी रिज, देयर इज एन इम्पॉर्टेंट आस्पेक्ट. ठीक है, what is the important aspect? The important aspect is that whenever you are going for it, so the thing is that you have to make a mucostatic impression for a flabby tissue. Why? Because you do not want to compress it, because it gives poor support. सोचो, mucocompressive impressions, if you make in a flabby ridge, they are itself providing poor support. They are already compromised. You don't want to compress the tissues more. So I will tell you the how to make impression, but just write down. Okay, the bone, when it is resorbed, it is being replaced by a fibrous tissue. That's why it becomes mobile, hyper redundant. Okay, As I told you, the best common example is combination syndrome. You see hypermobile tissue in anterior maxilla because of excessive load on the residual ridge and unstable occlusal conditions, as we see in combination syndrome, or what we can see Callies syndrome. Callies syndrome, right? Now, okay, we will just talk a very little about the, you know, the what are the, how does this Kelly syndrome occur? I'll just tell you the pathophysiology that was given by Kelly. It was also been explained by Saunders. Okay, but what Kelly said is that if you see in the diagram, if this we get a continuous incising force, or you know, we get this. Normally it occurs when we have a complete denture being opposed by a distal extension case and we have remaining mandibular anterior teeth. If you have, then we might encounter combination syndrome or Kelly syndrome. Now, what is the pathophysiology? Understand this thing. When we are talking about the pathophysiology of the combination syndrome, see, because there is a lot of proprioception, the proprioception is present only with respect to the lower anteriors, right? Now, when the patient is eating, normally when the patient eats, he will definitely try to eat from the anteriors because teeth and proprioception are present. So, with time, there is frontal rotation of the mandible like this. Okay, like this. Now, when this happens and you give a denture on the upper arch, so normally it will hit on the incisors. Normally it hits on the incisors, this premaxilla. Because of the continuous force in the premaxilla, it will go the labial cortical plate and this bone resorbs. Now, when this bone resorbs, what will happen? A flabby tissue will be forming. Now, the denture becomes slightly mobile. Okay, the denture becomes slightly mobile and it will rotate like this. So, when it will rotate, it is giving what? It is giving an injury. Now, when it is giving an injury, it will, you know, cause denture irritational hyperplasia. Now, when this happens is that when the patient is doing like this, because this incision continuous, ये anterior है, posterior, तो continuous suction is being formed like this. ये वाली movement चलती रहती है. So, because the PPS is being activated so much, the articles that I have read, it says that because of that continuous pressure, because of the continuous suction, the problem is that the tuberosity, there is a downward growth of the tuberosities, and even it becomes fibrous in nature. What will happen if the denture, if it grows, your denture will move like this. So what will happen if it moves? There is derangement of occlusal plane. So when there is a derangement of occlusal plane, then what will happen if a denture becomes like this? So the lower anteriors, now they will not find any companion to hit, so they will become supraerupted and flared, and the vicious cycle continues like this. Now, how to avoid this situation? Either by in the first go, try to give, normally we give overdentures in mandibular arch because of the you know, occurrence of more resorption in mandibular arch as compared to maxilla. It is 4:1, anterior mandible, anterior maxilla, 4:1. Okay, so to avoid resorption, we might leave some central or lateral incisors in the maxillary arch. Even if the root stump is there, there is no problem. You can keep it. It will prevent resorption. teeth prevents resorption of the alveolar bone. Got it? So this is how the flabby tissue and everything is formed. Now this is, kindly take a note of this picture. This is a window technique where we are making the impression of the flabby tissue with the help of plaster. This is a window technique. Even we can paint it with your light body. So this is a controlled, minimally displacive impression of the flabby ridge. Window technique. For the rest, you can make it with your ZOE. You can make a window initially, and this you can just keep it and paint it. Okay, if there's a lot of flabby tissue, you can go for surgical removal. Okay, and you can wait for healing, but there is loss of sulcus, so you can just go with the alveoloplasty procedures, vestibuloplasty procedure, sorry. Then denture irritational hyperplasia. A common sequelae of wearing, as I told, ill-fitting dentures is the occurrence of occurrence of your tissue hyperplasia of the mucosa in contact with the denture border. Normally it occurs in denture border. Why? Because maybe the denture borders are very thin, overextended dentures. So they will cause continuous irritation in the denture. So what you will get these flaps. So this is because of irritation. You can see there are a lot of flaps, and between these flaps there will be bacteria, there will be food particles. Normally, again, these are asymptomatic until unless it goes to that much of a situation. If the patient doesn't stop wearing the dentures, then there might be a lot of problems. The only treatment for such cases is surgical removal. Right? So there is a proliferation of the tissue, especially after new dentures. So if somebody asks you if a clinical condition is given, okay, a patient was given a new or a recent complete denture wearer, comes after 4 weeks with such flaps on the denture border. Okay, there are various flaps. Patient is normally asymptomatic. Okay, so what it might be? So this is basically what? This is denture irritational hyperplasia, right? मैनेजमेंट है, एक तो डेंचर पहनना छोड़ो, शार्प चीज़ों को ठीक करो. ओके, सर्जिकल एक्ससीजन होना चाहिए, राइट? इफ देयर इज अ लॉट ऑफ प्रॉब्लम, you may also palpate the lymph node, there might be a cancer too. You have to rule out cancer or squamous cell carcinoma. Traumatic ulcers might develop. Yes, it might develop because of if there are nodules in the denture, sharp areas, ulceration hoti hai, gray necrotic membrane are there, and there are more of elongated ulcers. Traumatic ulcers are normally elongated, and you will see inflammatory halo around it, form elevated borders because of trauma. So you have to understand that are these ulcer traumatic because of dentures. You have to trim you can use a pressure disclosing paste in the dentures itself, and then you can reduce the dentures for such cases. You can see, can you see it? Can you see these gray necrotic membrane surrounding by a red halo, right? So you have to treat it as soon as possible. Even you can, if there is lot of irritation, patient is still using that same dentures, there might be squamous cell carcinoma that may be developing. You have to be very, very careful. Burning mouth syndrome. Earlier, I'm teaching burning mouth syndrome for the last 12 years, and I told my students that yes, one day you will definitely get a question. Nowadays, in the last 3-4 years, this has become one of the favorite topic for the examiners. So burning mouth syndrome. Now understand one situation, that if you find a patient that he or she says that uh, a new denture is given, earlier there was no problems, but when I wear the dentures मेरे मुंह में जलन होती है, आई एम फाइंड एज इफ किसी ने मेरा मुंह जला दिया है, a burning sensation in the oral cavity. So what you will do as a dentist, you will just, just after removing the dentures, you will just clinically examine the oral mucosa. Normally you should find what? Ulceration, erythema, etc. But to your surprise, the mucosa is absolutely normal. What you should do? क्या करोगे अब? शार्प स्पिक्यूल है नहीं डेंचर में, म्यूकोजा बिल्कुल नॉर्मल है, क्या घिसोगे? How will you adjust the dentures? So there are two terms. One is burning mouth syndrome and burning mouth sensation. So whenever there is a term known as burning mouth sensation. So burning mouth sensation, there will be always a cause. Remember this. In a burning mouth sensation, the oral mucosa or the tissues will be inflamed for sure. But there is no inflammation in burning mouth syndrome. Normally, one very characteristic feature you find in burning mouth syndrome is that mainly you find menopausal women above the age of 45-50, post-menopausal denture wearers, women, female patient, it might be associated with menopause. Because of hot flushes, you might have a burning sensation, maybe, may not be. Still the symptoms and everything cannot be concluded till now. But if the term you ask is that mechanical burning mouth sensation, then there will be some irritation, there will be some inflammation, there will be some cause. It won't be idiopathic. Burning mouth syndrome is a idiopathic thing, right? Local factors might be there because of you have to rule out every diabetes patient on long-term immunocompromised status, geographic tongue. You have to see patient should not be having the xerostomia, any vitamin deficiency, especially vitamin B12 deficiency or folic acid deficiency, iron deficiency, anemia, diabetes, anxiety, depression. Yes, there are various psychogenic factors also, remember this. So you should take a history, you should take a psychological history for depression, anxiety. So you will find a female patient, for example, if I have to frame a question, a very anxious female patient above the age of 50 comes to the dental clinic after recent insertion of a denture. The patient complains of burning sensation in the mouth, and that increases during the day. Okay, the dentist remove the denture and observes the mucosa appears to be absolutely pink without any irritation. What it might be? It is burning mouth syndrome. It is not a burning mouth sensation. Okay, so there might be associated dryness, there might be as I say that there might be irritability, because patient क्या बोलेगा? Patient तो बोलेगा जी आपने कर दिया, पहले तो था नहीं, डेंचर देने के बाद ही हुआ है जी, अब आप ठीक करो उसको. नाउ यू डोंट नो द कॉज. फिर आप इतने सारे तीर मारोगे कोई ना कोई जाके लग ही जाएगा, पर इट वोंट बी ट्रीटेड. पेशेंट पहनेगा नहीं डेंचर. इट माइट बी एसोसिएटेड with iron deficiency, anemia, sore tongue. These are the various features. What are aggravating factors and relieving factors? Your hot food, tension, fatigue will aggravate. Soft food eating, distraction therapy, more sleeping will definitely, it will reduce or alleviate the relieving factors for burning mouth syndrome. Management, पहले तो कोशिश करो you find the cause, then you should always counsel the patient if there is any fear. Okay, if possible, you can also send the patient to a psychiatrist if you find any very hyper anxious patient or patient in depression, psychogenic factors. If you have to rule out, residual disk resorption important. Okay, if you see residual ridge resorption, again it is a sequelae for complete denture wearing. When there is a continuous loss of bone after tooth extraction and placement of complete denture, then it might be cause a residual ridge resorption. Now there are three terms. It might be physiologic, it might be pathologic. It is irreversible loss of bone, remember this. It is cumulative. Cumulative means it occurs over a period of time. So there is loss in quantity as well as loss in quality of bone, residual is bone. Okay, got it. So what are the factors? Definitely extraction is one of the factors. Maximum changes after extraction in the ridge takes place 3 to 6 months after the extraction. Okay, so it is chronic, progressive and irreversible loss of bone resulting in severe impairment of prosthetic restoration and oral function. ठीक है. As I told you that it maximum occurs within first 6 months and it is more in anterior mandible than in anterior maxilla. Okay, you see lot of resorbed ridges mandible that you are always fearful of. We all see such situations. So try to avoid these by saving teeth, by at least saving bilateral canines and bilateral premolars, because then you can give a tooth supported overdenture. And by giving tooth supported overdenture, you are actually preserving the alveolar bone. Just do intentional root canal, reduce the height according to the space available for overdenture, and again you can go for the overdenture treatment that will prevent the bone loss not only around the abutment but also between the abutments. So you can reduce the rate of resorption of bone, no doubt about it. Okay, so there might be some anatomical factors, prosthodontic factors, metabolic and systemic factors if the patient is having osteoporosis, vitamin D deficiency, calcium deficiency. Anatomic factors, you see that it is more in mandible as compared to maxilla. Yes, you will see more resorption in short and square face with elevated muscles of mastication. Means that especially in short and square face, it is associated. Just right now it might be associated. If the patient is wearing dentures for a lot period of time without going for recalls with the dentist, so it might even cause your residual resorption. Osteoporosis, I have told, osteopetrosis, vitamin D deficiency. What are the consequences? Definitely if I see that resorption of the bone in maxilla is centripetal towards the center, that will make the maxilla more smaller, and in the mandible it is from inside to outside, so it is more centrifugal, so it will make the mandible larger. Okay, so you should go for systemic evaluation, diet, prosthetic management mein you can go ahead with various techniques like your McCord's technique or Admix technique. You can go ahead with all green technique. Okay, basically you have to go ahead with the controlled pressure techniques. Do not never ever increase the VD in such patients, because already you can use flat teeth in resorb ridges, right? You can reduce the number of teeth, you can omit second molars. Okay, you can use a more softer material, acrylic teeth, right? If you find that there is a loss of bone, so there will be loss of sulcus also, so you can go ahead with vestibuloplastic procedures. Okay, so that you get more retention, more seal, peripheral seal. You can use grafts. Okay, so there are various indirect sequelae. See, so If we talk about indirect sequelae of complete dentures, so there might be atrophy of masticatory muscles. इट इज़ इनडायरेक्ट सीक्वल. देखो पहले जब पेशेंट के दांत हुआ करते थे तो उसकी मैस्टिकेटरी मसल, मैस्टिकेटरी पावर बहुत स्ट्रांग हुआ करती थी. अब डेंचर के कारण डेफिनेटली, बिकॉज उसकी एफिशिएंसी ही 1/5 है एज कम्पेयर टू नेचुरल डेंटेशन, सो दिस इट विल लीड टू एक मस्कुलर एट्रॉफी कर देगी. ठीक है ना. और स्पेशली फीमेल्स में ज़्यादा होती है. तो you can use over dentures, implant supported dentures. Got it? Inability to eat. पेशेंट बोलता है हम खाना नहीं खा पाते डेंचर से, तो एक तरीके से न्यूट्रिशनल डेफिशिएंसी में ऑल्सो भी एन इनडायरेक्ट सीक्वल है. ऑक्लूजल बैलेंस नहीं है, ऑक्लूजल प्लेन बहुत ऊपर है, पुअर रिटेंशन स्टेबिलिटी है, टीथ अच्छे नहीं लग रहे उसको, कस फ्लैट कर दी है आपने बिकॉज ऑफ रिज रिजॉर्प्शन. सो दीज आर दी थिंग्स दैट यू हैव टू बी केयरफुल ऑफ. शॉर्ट टर्म इफेक्ट गैगिंग है. ठीक है. इफ यू आर ओवर एक्सटेंडेड डेंचर्स, अंडर एक्सटेंडेड डेंचर्स, सो गैगिंग बेसिकली एक रेचिंग सेंसेशन है पेशेंट को. ठीक है. तो यू हैव टू सी, यू हैव टू मार्क द पीपीएस एरिया in a correct manner. It should not be hyper extended dentures beyond the PPS area. Okay, so you have to be careful. पेशेंट का ऑक्लूजर स्टेबल नहीं है, लूज डेंचर्स हैं, वीडियो बहुत इंक्रीज है, बॉर्डर्स बहुत थिक है. तो दीज आर द वेरियस प्रॉब्लम्स दैट कैन लीड टू गैगिंग. क्लियर है. हाउ टू स्टॉप गैगिंग? बेटा देर आर वेरियस फैक्टर्स. देखो गैगिंग का फिनोमेना समझना जरूरी है. इट इज 9th and the 10th nerve, 9th and the glossopharyngeal and the vagus nerve that are involved in gagging. So if the posterior part of the tongue is involved, so it is basically what? Glossopharyngeal. If the posterior part of soft palate is involved, it is supplied by vagus. So if somebody asks you what are the various cranial nerves involved, so it is basically 9th and the 10th nerve that is involved in gagging. Mainly 9th and 10th, right? So अब what are the triggering factors of gagging? So there are various. Now one theory came for gagging is trigger zone theory, right? Now trigger zone theory. So there are trigger zones in the soft palate and the posterior part of the tongue, where if constantly we are irritating those trigger zones. So these trigger zones are basically what? There are various nerves around it or in it. So whenever there is a firing, so the nerves will fire and patient will have lot of gagging sensation. So ये trigger zones संभालना और पहचानना बहुत ज़रूरी है. ट्रिगर जोन्स मेनली हमारे पोस्टीरियर पार्ट ऑफ द टंग और पोस्टीरियर पार्ट ऑफ द सॉफ्ट पैलेट में होते हैं, जिसके कारण पेशेंट को क्या होती है? गैगिंग होती है. प्रिवेंट कैसे करोगे भाई? प्रिवेंट करने के लिए गैगिंग को पहले तो आपको डेफिनेटली देयर आर सम डिसेंसिटाइजेशन थेरापी. डिसेंसिटाइजेशन थेरापी में क्या करोगे आप डायरेक्टली ही फार्माकोलॉजिकल थेरापी आप यूज नहीं करेंगे. फर्स्ट यू विल यूज अदर थेरापीज लाइक योर डिसेंसिटाइजेशन थेरापी, वेयर you are actually desensitizing the posterior part of the palate and the tongue. So how can you desensitize? Either एक बार अगर आपने प्राइमरी इंप्रेशन बना लिया तो जस्ट मेक a finished, highly finished and polished base plate over it and give it to the patient. कम से कम 10-15 मिनट पहनने दो, चाहे वो 2 मिनट पहने. So your palate and the mucosa will get the feel of it. So it will basically what? It will desensitize that area because the patient is wearing the base plate. And so once the patient is okay with it, so it will be easier for him to adapt and can go ahead with the procedures, next procedures of the denture. Other desensitization, earlier there was a marble roll technique where वो था ना बंटा कंचा इतना मोटा जो बंटे में निकलता है, वो रोल करता था पहले पेशेंट बिटवीन द टंग एंड द सॉफ्ट पैलेट, तो डिसेंसिटाइज हो जाता था. तो दीज और आइसक्रीम स्टिक से भी, थम बैक ऑफ द थम से भी कर सकते हैं, बार बार हम मसाज कर सकते हैं. So these are basically causing desensitization therapy. Then there is distraction therapy. So when distraction therapy, we all know, you must have seen when the patient is gagging, you say that हाथ ऊपर करो, पैर के तलवे चलाओ, उसमें कुछ होता कुछ नहीं है, but patient का mind distract होता है. तो it works wonderfully well, no doubt. Okay. One more clinical tip that I can give it to you is that if you can use salt on the tip of the tongue, it can create wonders. It can reduce gagging. You'll be surprised. किताबों में नहीं दे रखा. Okay, so even then you can inject, or you can just use a local topical anesthetic on the posterior part of the palate and the tongue. Okay, got it. And otherwise you can also use antiemetics, that is the last reserve that you can use half hour before the procedure. Okay, so some patients, they will see the impression trace and then gag. They will see the impression compound and gag with the smell, with the odor. So you have to manage such patients. They are difficult patients, no doubt. You will require long sittings, multiple sittings, right? Then you can see ulceration because of overextended dentures, loose dentures, क्योंकि आपकी सील नहीं है उसमें, राइट. जीरोस्टोमिया है पेशेंट को, न्यूरोमस्कुलर इनकोऑर्डिनेशन है, स्पीच डिफिकल्टीज हैं. ये दीज आर दी वेरियस प्रॉब्लम दैट यू कैन. नाउ अगेन आई विल टेल यू देयर आर सम प्रॉब्लम्स. अब नाउ आई एम आस्किंग यू, इफ द क्वेश्चन सेज दैट, okay, now in 5-10 minutes I'll just wrap it up. Now I will ask you some questions. You kindly note it down. Very, very important is that if you have given a denture to the patient and it's a recently inserted denture, and the patient says that he experiences a feeling of sore throat, what is happening? Because your denture, write down, because your denture might be too much overextended in the distolingual area. It might be the superior constrictor muscle might be brushing on that overextended area. That might cause a feeling of sore throat. So kindly reduce that distolingual area, and we do not want any injury to superior constrictor muscle, because when the patient is swallowing, because it's a swallowing muscle, when the patient is protruding, that overextended part of the denture is brushing against the superior constrictor muscle. So you have to be careful. Then if somebody asks you that the upper denture in the lateral movements falls down, or it gets dislodged, so it might be because of the thick distobuccal area of maxillary denture. Write down. If the patient opens the wide mouth, if the patient takes the mandible laterally, right or the left, it might be because of the thick distobuccal border of the maxillary denture. So what you have to do, you have to make that border thin. The distobuccal border is also known as coronomaxillary flange area. So that is why you see that area is limited by buccinator, by how much amount of resorption, even the contraction of masseter, and also the coronoid process of the mandible. So you have to be careful. You have to record the movement of coronoid process by asking the patient to do the sideways movement during border molding procedure. Got it? Got it. Then a question might be that a patient smiles and the denture comes down. When the patient smiles, it is the zygomaticus major and the smiling muscle that gets activated, and if you have not given relief in the maxillary buccal frenum, where you have three muscles, that is your orbicularis oris, your buccinator, and your levator anguli oris or caninus muscle. So if you have not given enough relief, so definitely these muscles will dislodge the denture. Clear hai? Clear hai? Another question that might be asked is that which is the thinnest portion of mandibular denture. So the thinnest portion of mandibular denture is the labial flange. Labial flange. Why? Because of the action of orbicularis oris, that is the oral sphincter. So because of its action, if you keep it thick, the maxillary labial flange, if you keep it thick, so your muscle orbicularis oris and hypermentalis muscle might dislodge the denture. Got it? Got it? I hope it is clear. What is the secondary peripheral seal area of mandibular denture? Write down. The secondary peripheral seal area of mandibular denture is anterior portion of alveolingual sulcus or anterior vestibular portion of the mandibular denture. Okay? Got it? Clear hai? Then if somebody asks you that if the patient opens the mouth wide and the mandibular denture comes out, so it is because of overextended buccal or clear hai? Clear hai? So you should always try to first. So okay, one more thing that I want to tell is that if somebody asks you that in a patient who has neuromuscular disorders, so you will definitely, the most difficult step in a patient with neuromuscular disorders is jaw relation. So actually you don't record an actual jaw relation, you just record an optimum jaw relation. Okay, because the patient is showing uncontrolled movement like this, repetitive movement like this, with tongue, jaw, so you cannot go ahead with. So in such a patients, you always, the first choice is implant supported fixed prosthesis in neuromuscular patients. If you cannot go ahead with an implant supported fixed prosthesis, the next best choice is implant supported dentures. The worst choice is a conventional CD in such patients, right? So as I told that, any questions that you want to ask right now regarding this? Any questions? Let us wrap the session. I hope okay, one more thing I want to tell you is what is mesenteric notch, that most of you don't know. So basically in the most distal portion of the, देखो याद रखो के I wish to take the landmarks with you. I'll definitely take in my next classes the maxillary and the mandibular landmarks. You will come to know the various questions that are being asked in my next classes. So just I will tell you today mesenteric notch, about the musculature here in the buccal and the most distal portion. Remember one thing is that when your muscle is oriented parallel to the denture border, it is a passive muscle. It won't dislodge a denture during function. But if it is contracting at 90 degrees to the denture border, so kindly do not come in the way of a contracting muscle at 90 degrees. या तो तुम उसे शॉर्ट पहले ही मुड़ जाओ, या उसे पूरा कॉन्ट्रैक्ट, इतनी स्पेस दो कि वो पूरी 90 डिग्री कॉन्ट्रैक्ट हो जाए, अपनी हाइपर कॉन्ट्रैक्ट स्टेट में हो. You have to slightly be away from the muscle. So in the buccal area of the mandibular denture, there is a muscle known as buccinator that is oriented parallel to the denture border. It won't dislodge the denture. But in the most distal portion, if this is buccinator, so behind it and below it there is masseter. And it's a very strong muscle. It is passive. Buccinator is passive, but masseter is very strong. So when it contracts like this, it forms a bulge on the buccinator. So question comes is how this is forming? This is forming by the action of masseter over buccinator, not the other way around, mind you. Masseter is a very powerful muscle. अगर वो contract करेगी तो वो इसको ऊपर उठा देगी buccinator को. So basically what it does is it will cause a bulge that will be recorded as a notch in the impression or the bottom molding area. It might be strong, it might not be strong, and you, ये कोई ज़रूरी नहीं है कि हर केस में बने. रिमेंबर दिस. अगर ज़्यादा एक्टिव होगी मैसेटर मसल तो ज़्यादा आपको नॉच ज़्यादा मिलेगी, कम होगी तो कम मिलेगी, और बिल्कुल नहीं होगी तो बिल्कुल भी एक्शन नहीं होगा तो कुछ नहीं मिलेगा. So this is how, and mind you, same type of notch is being formed lingually. You people don't know about it. In the distolingual region or the retromylohyoid curtain, you see that posterior medially there is palatoglossus, posterior laterally there is superior constrictor, and behind and below superior constrictor there is medial pterygoid. So when we are recording the action of, on the buccal side, the action of masseter over buccinator and medial pterygoid over superior constrictor, तो हम क्या करते हैं, हमने बॉटम मोल्डिंग ग्रीन स्टिक लगा दिया बक्कल लिंगुअल या एरिया में. We ask the patient to close against resistance. So when the patient is closing against resistance, both of these muscles become activated. You have to find out if is there any action of masseter over buccinator or the action of medial pterygoid over superior constrictor. Remember this. You have to record it. It is important. Otherwise, your denture might get dislodged during function while eating. I hope you people have understood the concepts today in complete dentures. I will try to, because it's a very very vast subject, I will try to take more classes on complete dentures. So thank you so much. Okay. So here I any doubts? Any doubts, students? If you're having any doubts, kindly write down. I'm waiting for 1 minute if you write any doubt till in the session. Don't worry, beta Seema, I'll definitely teach this in my next classes. I'm waiting. If you have any doubts, kindly write in the message. Okay, I'm not finding it. So thank you so much for joining. Stay blessed, work hard, and do not leave anything unturned, right? Discipline is the key.